What is trauma-informed care and why does it matter? Hi, I'm Dr. Rebecca Berens, founder of Vida Family Medicine. When people hear the term trauma-informed care, they sometimes think it's not something that can be done in a traditional medical practice, or they think that it only applies in therapy or mental health settings. But trauma shows up in every part of healthcare, from how we take a history to how we conduct an exam to how we discuss and explain results and come up with a plan. And so it's really important that we are thinking about this for anyone in the healthcare profession. And I practice and am passionate about trauma-informed care because I believe it can and should be standard. And so today I'm going to share what that means and why it matters for both patients and the clinicians that care for them. So first off, what do we mean when we say trauma? I think trauma is kind of becoming a little bit of a buzzword now, and it's losing some of its meaning. So I want to talk a little bit about what trauma actually is. So first of all, trauma is not just the big obvious events that happen to people, like big accidents or violence or wars, those sort of big events in people's lives. Trauma can also be chronic and sort of smaller events over time that build. So that can be chronic stress from food or housing insecurity, or other forms of chronic stress. It can be racism or other forms of discrimination. It can be medical trauma from chronic illness or a major medical condition. It can be weight stigma, or it can be any other experience where a person's control or dignity was taken away. And so for many patients, just walking into a doctor's office by itself before anything else happens can bring back those feelings of being dismissed or ignored or shamed. There's inherently some power dynamics at play between a doctor and a patient based on the way that our system has been built and the history of how medicine developed, that further amplifies those feelings. And so trauma-informed care starts with understanding that anyone we meet could have that history. It's not obvious from looking at a person if they are going to experience trauma in the medical setting, or if they have in the past experienced trauma in a medical setting. And so whether we know it or not, anyone could have this history, and it's important for us to keep that in mind. There's 5 key principles that guide what trauma-informed care is. So the first is safety, and that means creating an environment that's both physically and emotionally safe. And this goes for the patient and for the physician. So we want to make sure that everyone feels safe, everyone feels that they have the ability to leave at any time, that they do not feel held against their will, and that they feel able and willing to voice any concerns or questions that they have without fear of judgment or blowback, or any sort of negative reaction. The second is going to be trustworthiness and transparency, and these go hand in hand. So we need to be honest about what we're doing and why. We need to give people all of the information, and give them that information up front so that there are not any surprises and everyone feels that they have all of the information they need to make a decision. And that's number 3, choice. So always, anything that we do in a medical setting, the patient has a choice to do or not do, and there may be some consequences to choosing to do or not do something, and it's important for them to have that information as well, but it always is a choice. There's never anything that should be forced in a medical setting, and so it's important for us to be keeping in mind that the patients do have a choice. Number 4 is collaboration. So this means we're working with the patient to meet their healthcare goals. We're not doing things to them to meet our own goals. And so everything that we do is a collaboration between the clinician and the patient. We are working together to meet the goal of making that patient healthier, have better quality of life, better well-being, all of that. And so we are working together. It's a partnership, it's a collaboration. And then the last is empowerment. So this means that we are supporting the patient in making an informed choice and having the autonomy to do so, and also the empowerment to be able to do other things to help take care of themselves. So they're not so dependent on a medicine, a surgery, a procedure, whatever else it is. We're giving them all of the tools so that they can take that back to their regular lives and improve their own outcomes. So empowerment is very important as well. And so we're integrating this into every visit, and when we do that, we are reducing re-traumatization, and we're building a true partnership between the clinician and the patient. So why is this needed? Unfortunately, as I'm sure anyone who's experienced modern healthcare can attest, traditional medical training is really prioritizing efficiency and hierarchy. And that has to do with a lot of reasons. Part of it is there's limited resources and in healthcare, limited numbers of doctors and nurses and other healthcare professionals, and there's a lot of patients. And so we need to try to distribute those resources in the best possible way to help the people that need help get the help that they need. And that's challenging, especially in a modern climate, and when payment is an issue and all of that. And then there's also hierarchy, and some of that is appropriate, right? Sometimes there is a legal hierarchy that we follow in terms of, a doctor is providing an order that another healthcare professional is maybe carrying out, and that has to do with the different levels of training of those professionals. But it also goes the other way. Other healthcare professionals may have an experience or an observation about a patient that they need to bring back to the doctor and feel confident saying, hey, I know you ordered this. This is what I'm seeing in the patient, and I need to just let you know that to double check that this is actually still what you think is the right call. And so some of the hierarchy is legal, some of it has to do with training, but always it should go both ways. But unfortunately, because of, particularly in the US, the legal structure and malpractice and just laws that govern different areas of practice of medicine, the hierarchy and the efficiency can kind of take precedence over empathy and the human connection with the patient. And so the way that plays out is often we ended up rushing through things that can be pretty sensitive topics. So you may come up with it to a patient just going through a medical history, and to the doctor it may seem just like one more thing on the list to check off, but to the patient it reactivates a really painful memory or brings up a really sensitive discussion that they're really not ready to have in that moment. And that can be really hard for the patient to then feel safe and comfortable continuing with the rest of the exam. The other thing that often happens too is there's sort of this assumption that like, oh, well, you're here, so you want us to help you, so you're just going to do all the things we recommend. And that's just not the case. That's not to say that the patient won't choose to consent to something once you give them all the information, but you can't assume up front that they're going to do everything that you ask of them. And you can't then say, well, I'm not going to care for you if you don't do all of the things that I ask of you, because that also reduces that safety and that trustworthiness and that collaboration and empowerment and choice. So it is really important for us to be able to take into account that the patient has the right to choose, and we should never assume consent, and we need to give them all of the relevant information so that they can make the right choice. The other thing that often happens is doctors tend to be pretty numbers focused. And some of this is appropriate. Part of our job is to make sure that we are keeping track of the numbers and keeping track of what is going on with a patient, their vital signs, their lab results. These things are things that affect the patient's health, and it is our job to be aware of them and manage them as best we can. But that also can mean that we're focusing on a number that to a patient is not all that relevant, and there may be a lot of other factors in that patient's life that make them feel like getting this number optimized is not the most important thing to me, and I really want to take into account the big picture of what's going on in my life and make a decision about what's the most important thing to prioritize right now. This is further amplified by the fact that doctors, especially nowadays, are getting graded by insurance companies on the numbers. So they are getting graded on how many of your patients have their blood pressure controlled, how many of your patients have their diabetes controlled, evidenced by their A1C being below a certain threshold. There's a lot of these numbers that doctors are being held accountable for, and it makes it a little bit difficult for them to then help with a patient prioritize like what is most important to you. Maybe it's not this number right now. And so it's challenging, but I think it is really important to take that into account when we're looking at a patient, because the big picture is so much more important than the individual numbers. And so, I think one of the ways that we can kind of combat this sort of structural and systemic barrier that's been put in place between doctors and patients is by just sort of slowing down and introducing that humanity wherever we can. And it starts with just asking permission. So if we are, for example, going to be checking someone's vital signs, asking first, hey, you know what? I need some information to help me make a treatment plan. I would like to have you step on this scale and check your blood pressure. Is that okay? Are you comfortable doing that today? Just asking the question opens up that autonomy and choice for the patient, that more often than not, they're probably going to say yes, but they now feel like, hey, I actually had a choice in this. It was not forced on me. And it gives them back a little bit of that control, breaks down a little bit of that hierarchy and barrier, and can make a huge difference. And it really doesn't take that much more time. And in fact, over the long term, it really saves a lot of time, because if you're able to get the patient to feel comfortable, they're going to feel more comfortable openly communicating with you about other things, and you're going to get more accurate information. You're going to get the full story. You'll be better able to understand what's actually going on, come to a diagnosis faster, and make a plan together with the patient that they're actually willing and able to carry out and follow through on, which ultimately is going to improve their outcomes. So it's a couple seconds extra time up front that can have huge implications later for improving outcomes and saving time as well. And so, all this to say, trauma-informed care is not just a buzzword. It is not just a gimmick or a fad. It is something that is truly bringing humanity back into medicine and changing the question we ask when we see a patient from what's wrong with you to what happened to you, and how can we help you feel better, have the improved quality of life, duration of life, whatever your goals are in health. How can we help you get there safely and in a way that feels good to you, that you have some control over? And so in the next video, I'm going to share how we apply some of these principles every day at Vida Family Medicine. I encourage you to follow along, and I look forward to any comments and feedback.